Thank you. Assalamu alaikum. I think planning valve-in-valve starts with the first procedure, whether it's surgery or TAVI, and this should be optimized for the future management, especially we are moving toward young population, either in TAVI or in bioprosthetic valve. We know that the outcome of valve-in-valve is either equivalent or better than reduced surgery, especially in high risk and intermediate risk, and even in low risk patients, the outcome is almost the same. However, the success of a valve-in-valve program depends on meticulous and multidisciplinary team approach to evaluate the patient. I think everyone should have an algorithm. He should go step by step how to plan and how to assess whether the patient is suitable for valve-in-valve or not. The first step is that you have to assess what's the mode of failure. And this is done by transthoracic, TEE, and by CT scan. Whether is it structural valve degeneration or non-structural? Is it endocarditis? Is it thrombosis? And whether it's suitable or not suitable for valve-in-valve. And the importance of that is that patients with stenosis, for example, they have higher mortality and worse outcome than patients with aortic regurg when they go for valve-in-valve. So now you decided that this patient has a structural valve degeneration, either regurg or stenosis, and he's suitable for valve-in-valve. Then you will look at the valve. What kind of surgical valve or even transcatheter heart valve, which we will come to later if the time allow. And when you look at your surgical valve, there are several points you have to look at. The first is the valve design. Are the leaflets mounted outside or inside? Is it stented or stentless valve? Because outcome is different and risk of coronary obstruction and mortality is different according to the valve, where the leaflets are mounted and whether it's stented or stentless valve. The second is the valve size. Valve size is related to patient-prosthesis mismatch and is related to outcome and mortality. You have to know how to measure, where to measure, and the different designs and different internal diameter of these valves. Again, outcome and mortality is related to the valve size. The smaller the valve, the higher the mortality and the worse the outcome also. Third is visibility. Can you see the valve very well? You have to know how does it look on fluoroscopy or on X-ray, because visibility is related to malposition. Most likely, if you cannot see the valve, then you will not position it right. Then probably you will have either a severe paravalvular leak or pacemaker or other complications, including migration of the valve to the LV or to the aorta. So now we decided that this patient is suitable for valve-in-valve. You go to the third step, which is you assess the risk of coronary obstruction and you assess the risk of patient prosthesis mismatch. Coronary obstruction can be assessed by CT and also by TEE or transthoracic echo. And angiography, by the way, you have to use all multimodality imaging to assess the suitability for valve-in-valve. And it depends whether your valve extend above the coronary or below the coronary. If it's above the coronary, whether it extends above the sinusotubular junction or not, and whether the sinuses are large enough to accommodate your other valve or not. Again, you have to know the valve design, because those who are mounted with leaflets mounted outside, there's a higher risk of coronary obstruction and sinuses sequestration. Then from this, you can decide whether this patient is suitable. If the measurements, if the aortic root type and the valve design allows for valve-in-valve, then you can go ahead for it. However, if it does not, then you have to sit back and assess. Can I deal with the obstacles that I have? Can I go for coronary protection, for example? Can I fracture the valve or not? If you can go for coronary protection, then you can deal with it. You can also lacerate the leaflet using the basilica, or you can fracture the valve if you think that the patient may end up with high gradient. Again, you have to know which valve you can fracture, which valve you can only remodel or you can dilate only or extend, and which valve you cannot remodel or you cannot fracture, and these patients are better served with surgery. And if you decide to fracture, again, you have to look at the advantage and disadvantage, whether of doing it before or after implanting the valve. At the end, you have to look which valve is suitable for which patient. Those who have small prostheses, they are better served with supraannular valves. If you need coronary access, probably it's better to use a balloon expandable valve, and so on. If you need to fracture, if you fractured before, then probably a balloon expandable valve is better for that patient. And then using the app in the Apple Store, the Valve in Valve is very helpful to decide which size, how to implant, and even it shows you a video of how to implant the valve and about the visibility of that valve. If we move to transcatheter aortic valve replacement, we are moving to young. We know that from registries like the Vizient registry, that almost 48% of those who are less than 65, they are going for transcatheter heart valve or TAVI. And these patients, they have long life expectancy, and most likely they will need a second or a third procedure. This procedure should be optimized from the beginning. You should choose the right valve that really fits that patient's anatomy so that you can treat him in the future, or whoever comes in the future can treat that patient with valve in valve. Don't look at the index procedure. Always look at the future. And we know from multiple registries and observational studies that valve in valve is safe. It's safer than explantation and safer than reduced surgery. And it is a successful procedure with low complication rates if it's executed in the right hand and with the right pre-assessment. The first thing you have to look at is you have to review the first CT. You have to review whether that valve was deployed right, was the sizing right, and was the position also right. Then you have to assess that valve. You have to know the skirt, how long it is, the cells, the leaflets height, and so on. The third step, you have to know the position of that valve. Is it really in the right position? Is it low? What's the mechanism of failure? Is it paravalvular leak because it's low? Is it leak because it's high? Is it degeneration because it's undersized or it's not fully expanded? Fourth or fifth, you have to know the terminology. The first terminology you have to know is the nodes, especially for self-expandable valve, where the links of the cells are, they serve as a marker where you can deploy the inflow or the outflow of your valve. And you have to know wherever, at which node you deploy your next second valve. It will dictate how long is your new skirt. It will dictate the risk of your coronary obstruction and the sinus sequestration. Again, remember that when you deploy a self-expandable valve, a balloon expandable valve in a self-expandable valve, you will change the expansion of that valve. And most likely you may sequestrate the sinuses if you do not take this into account. You have to know where to deploy the valve, whether at which node, whether you deploy it low, high, at 4, 5, or 6 nodes. And you have to know that with this deployment, you will either result in a long or a shorter new skirt, which is the pinned leaflet of the old valve. Again, at which node you deploy your valve will dictate how much the leaflets of the old valve will hang over the new valve. This is important if you have stenosis. In case of regurg, it will not affect your valve performance much. But it depends on if it's stenosis, then you aim at deploying the valve a little bit higher. Leaflet deflection applies to valves like accurate new, where when you deploy the valve, the leaflets will not be deflected fully to the frame, and this will allow for better coronary access. So you have to integrate all of these, the skirt, the hanging leaflets, the deflection, the nodes, to choose which valve you can dictate. Afterwards, you have to know exactly like in surgical valve, you have to know the aortic root anatomy, and according to that, you decide the size of the valve, the place you can deploy your valve in, whether you deploy it low or you deploy it high, and which valve to use, whether you use balloon expandable or self-expandable valve. Thank you.